All right, here we go. Hello, everyone, and thank you for watching this webinar on new patient processing and how to maximize reimbursement. There's no audio taping or videotaping allowed, and any unauthorized reproduction, dispensing, forwarding, or copying of this presentation is illegal. The information in this presentation is for educational purposes. We don't provide legal services. We don't engage in providing legal services. Every attempt has been made to make certain the information in this presentation is 100% accurate. However, it's not guaranteed. We have a lot of members of Target Coding on the line this morning listening to this, but for those of you that do not know who I am, I'll tell you a little bit about myself. My name is Dr. Marty Kotler. I'm a chiropractor. I practiced for 16 years, and about 12 years ago I started a company called Target Coding. I'm a certified professional compliance officer, a certified billing and coding specialist, so I consider myself a little unique because being in practice for many years and then transitioning my practice to an integrated practice, it gave me the opportunity to learn how to bill and code. So now I'm seeing patients, but now I have to bill in an integrated practice. So that gave me a little bit of a unique learning experience. So then I started writing articles to Chiropractic Economics on how to bill and code in a multi-specialty practice, and that's how Target Coding was formed. I started getting contacted from doctors all over the country asking me for my advice on how to bill and code in a integrated practice, and so I started consulting part-time, and then it grew into full-time. So I still take that unique approach. Being certified in coding and a chiropractor is unique because most chiropractors are not certified coders. Most certified coders are not chiropractors. I've written many books and training manuals on billing, coding, and documentation. I write articles to the major newspapers and journals and magazines in our profession. I also write articles on physical therapy and acupuncture. And I'm a guest speaker at many state association conferences nationwide. All right, so now let's get going here with new patient processing and how to maximize reimbursement. It all starts with the new patient phone call, right? When a brand new patient calls, the patient doesn't necessarily speak to the doctor, so the patient's first impression of your practice is whoever's answering the phone. Let's call that person your front desk receptionist. So this person needs to gather as much information as possible in the shortest period of time. That's the goal. So what information do you gather? Doctors, you should review this with your staff at least once a year to go over training, making sure they're not saying things they're not supposed to say. So you want to keep this conversation professional. You want to make sure that there's no background noise. Remember, this is a brand new patient calling. You got to give a good first impression. Some of my clients have asked me, they said, hey, Dr. Kotler, call my office as a secret shopper and let me know how my front desk receptionist handles your phone call. And most of the time it works out, but sometimes the front desk receptionist, would put me on hold for a long time. I'm a brand new patient, to be put on hold for 5 minutes, it's a little, it just doesn't feel right, or if there's a lot of noise in the background, or if you ask a question and your front desk receptionist doesn't know the answer to it, and, a complicated question, okay, but a simple question like, what are your office hours, and your front desk receptionist doesn't even know what your hours are. So make sure they're trained, guide the patient through their choices. How did they find out about the practice, right? That's a good question. Do you ask about their chief complaint? That's why you see on your screen it says maybe. If you ask a patient, so how did your back pain start? Now the patient could say, well, back in 1992, I was cleaning out my garage, so you don't want to get into too much of a deep conversation. Do you discuss money on the first call? What happens if the patient says, how much do you charge? Do you give them an exact fee? Front desk's receptionist listening to this, have you been trained as to what to say? I recently did a training. I did an on-site training. I went to a doctor's office, sitting in the waiting room, doing a training with the free, the office was closed, and we're doing a training in the waiting room. And I asked all 3 staff members, if a patient calls and says, how much? What would you say? One said, oh, we don't give prices. The next one said, "Oh, I tell them how much it costs," and the other one said, "Oh, I wasn't trained. I don't know what to say." So now, and the doctor is right there, listening to this, watching this, and he was like, "Wow, I can't believe my staff is not all on the same page here." So, I want to make sure that everybody is trained properly. Again, this is the patient's first impression of your practice. So for those of you front desk receptionists that cannot enter the information in real time into your EHR, then you should have a piece of paper or something next to you. So this is our new patient phone call intake form. Again, many staff members, when a new patient calls, they're right there entering the information right into the system. But I have probably about 30% of my clients, their front desk receptionists just can't do it for whatever reason, or maybe they don't have an EHR that's set up that way. So just have this. It reminds your front desk receptionist what to ask. There are certain very important questions, like, is your condition related to an accident or an injury? I'm sure those of you in practice for, I don't know, at least 7 to 10 years, you've had a patient come in, you're billing their regular health insurance, and out of the clear blue sky, the patient says, "Oh, my attorney wants a copy of my records." Whoa, what do you mean? Yeah, I was in an accident. Wait, you never told us you were in an accident. You never related to us you have an attorney, so get that out of the way. And then on the new patient, on the forms, which I'll show you in a minute, you got to go over that again. So there's a few really important questions. Have you ever seen another doctor for this condition? That may allow you to bill a consultation code. All right, so let's move on from the phone call to the actual visit. Here comes the new patient, walks in the door. Okay, patients need to fill out forms, right? Now, you could have the best EHR in the world. There's, everybody knows the most popular EHR programs in the profession. They advertise in all the major publications. So even if you have one of those really good software programs, you still need forms for certain things. So here's a list. This is a list of some of what we think are the most important forms. When a new patient comes in, just a general health history questionnaire, a review of systems. Yeah, that's a good form, very important. Those of you listening to this from New Jersey, if you're billing Horizon, Blue Cross Blue Shield, they really like to know about system reviews. I could tell you that from personal experience, talking to their investigators. Financial policy, yeah, that's a good thing to have to get. It's nice to get paid, right? How many times do, here at Target Coding, the help desk, where we get office managers and billing staff calling us, "Dr. Kotler, the patient owes us $420, doesn't want to pay. They keep, they don't return our calls." That happens all the time. So you don't want to chase after your money. It's one of the most frustrating things, in practice. When I would come in, especially on a Monday morning, and I looked at my accounts receivable, whoa, it was not a fun thing to look at. So those of you that come into your office and you see that your accounts receivable is $750,000, good news and bad news. The good news is that you could write off half of that probably. Just get rid of it. The other half, go after it. But you want to keep from chasing patients and insurance companies. So financial policy is really important. That ties into the authorization to release information and payment assignment. Deal with PI patients. Try to get the attorneys to sign a lien. Some won't. I have some friends that are PI attorneys. They would never sign a lien. They tell me they just refuse signing them. So, but if you can get an attorney to sign it, it's great for you, because now you have a contract with the attorney that they have to pay you. It's a nice thing to have. Informed consent, check with your malpractice insurance company on that. That's another thing. When we bring on our gold member clients, it includes a full forms review. Every form you have in your practice will review. So oftentimes we'll review these informed consents, and doctors are using informed consents that they've gotten online or they've borrowed from their friend. And it talks about the risks and complications of a chiropractic adjustment, stroke, fractured rib, and they're not using the appropriate form that's in line with their own malpractice insurance company. So be careful with the informed consent. That's malpractice prevention, risk management, consent to treat minor. Yeah, you got to have that. Hardship form. So get all the forms out of the way. Yeah, HIPAA forms also. Make sure you read your own HIPAA forms and you know what's in there. I was working, again, another story I'll share with you, working with a doctor, reading his HIPAA form. That's that new patient form. Here, I think I have, here's a sample. Oh, this is a welcome form. Here, notice of privacy practices. This is every new patient should be signing a HIPAA form. So I'm reading this doctor's HIPAA form as part of my evaluation of the practice. I guess the doctor never read the form. I guess his staff never read the form. I guess his patients aren't reading the form. I guess I was the only one to ever read it. I'm reading it. There's a lot of dental information in the HIPAA notice. So I asked the doc, what's all this dental information? He said, I don't know, but I got that form from my brother-in-law who's a dentist. Oh, so make sure you read your own forms. If anybody wants a copy of I might show a form here and there like this HIPAA form. If anyone would like a copy of this form, just send an email to amy@targetcoding.com, amy@targetcoding.com. If you see a form that you like that I flash on the screen here, let us know. We'll send it to you. No problem. Now, Amy's going to be out of the office until next week, so if you need any of these forms, don't expect her to get back to you. Our entire staff, we're all going on a seminar that's on a cruise ship. I'm doing a cruise seminar this weekend. First time. All my seminars have been on land, so we're doing our first cruise seminar. So the entire staff and team is going to be out of the office for the next week. All right, so now insurance verification. Now the patient came in, filled out the forms, great. Maybe while the patient's there, or maybe after they leave, or maybe even before they come in, you'll do an insurance verification. There's more and more of the doctors that I work with, I encourage them, contact the health plans before the patient even shows up. That's the ideal situation, in my opinion. But if it's just not possible, until the patient comes in, you make a copy of the card, and then you might not have a staff member available to call while the patient's there. You might not have a staff member to call for a couple of days to verify coverage. So then you're in this, mystery, especially if you're out of network. If you're in network and you've dealt with a plan for many years, basically what the patient responsibility is. But if you're out of network, or it's a new plan, or the beginning of the year and you don't know what the deductible is, if you don't call to verify coverage, it's kind of a little bit of a mystery. So try and do it as soon as possible. These are the 5 things you want to find out: E&M, testing, modalities, adjustments, obviously, and miscellaneous services. We have an excellent insurance verification form. We separate the PT services because some of our clients, all they do is chiropractic adjustments. We have quite a few clients that they're more subluxation based. All they do is adjustments and traction. And maybe they, do a couple of wellness consultations. But it's very simple. So they stay to the left, in the left lane there on your screen. And then, most I'd say, 80% of the chiropractic profession includes, therapies and modalities like, electrical stim and ultrasound and rehab. So we have it separated out. Now fees, that's another thing, especially, we have quite a few students that work with us and they graduate chiropractic college and they go, Dr. Kotler, how much should we charge? It's a good question, right? How much should we charge for an adjustment, for x-rays? So a couple of things here. What determines a fee? That's what we want to go over here. So these are the 3 factors that usually determine a fee: your work and skills, your overhead, and your malpractice. Now, how do you choose a fee? You should do research. This is a very important part of practice, your fees. I guess it could be in the top 1 or 2 or 3 items when you're dealing with running a business. How much should you charge? So you should really take a look, and again, at least once a year, reevaluate your fees. There are some doctors that are overcharging and they're writing off so much, and there are some doctors that are undercharging and don't realize that they can get paid more for certain services. So you should look at this very carefully. Now, you can go the real scientific way and buy a book where you can find out the RVUs, the relative value units, times the conversion factor for your specific county and zip code. Yeah, you could do that. Yeah, you should do that. And put that together with what do the other chiropractors in your town charge? You know, try and be a secret shopper, or if you have a friend that you could ask, hey, what do you charge? Maybe you want to take a look at the Medicare fee schedule in your area. Maybe you want to take a look at the in-network fee schedules in your area. Again, fees should be reviewed at least once a year. Now, is one fee possible? That's another question we get. Dr. Kotler, I just want to charge $50 for a chiropractic treatment for every man, woman, and child that comes into my office. $50 across the board. That's it. Can you do that? Probably not. Well, yeah, let's go with let's say your normal regular fee is $50. Now you go in network with a plan. You're not going to get $50. You're going to get less probably. Okay, now your normal fee is $50, but now you want to take a Medicare patient? Well, that's a mandated fee. You can't collect $50. It might be only $30. You have to write off $20, and then there's workers' comp and PI and cash. So it's hard to have one fee across the board. It's pretty much impossible to have one fee across the board for every man, woman, and child that comes into your office because of all these situations. I do have a few clients. They're a true cash practice, which means they do not see Medicare patients because they don't want to abide by the Medicare fee schedule. You know, so in my opinion, a true cash practice means you do not accept Medicare patients at all. You do not take PI. You do not take workers' comp. You're out of network with every plan, and every patient comes in and pays you at the time of service. That's ideal. Now, deductibles, co-pays, co-insurance. You know, we have a lot of new staff members listening to this. So deductible, quickly, is the amount that is paid by the patient prior to the insurance kicking in. Co-insurance? What's that? That's typically a percentage, and that applies to typically out-of-network providers. Copay is a flat fee that the patient is responsible to pay out of pocket. So if your fee is $150 and the copay is $25, that's it. The patient could only pay you $25, and you, the difference between the patient's copay plus the insurance payment and your total bill must be written off. So copay applies to in-network providers. Now, this is just pretty straightforward. And for some reason, a lot of doctors and staff members do not grasp this, this simple approach. You cannot waive copays, you cannot waive deductibles, you cannot waive coinsurance. You can't say, well, I'm only going to ask the patient to pay me $25 each visit. That's all. We'll write off everything else. Or, oh, this patient has a deductible. We're not going to have the patient pay the deductible. We'll just tell the patient, just give us, we'll just accept the patient. The insurance payment is in full. Yeah, no, can't do that. You could be accused of violating the anti-kickback statute. Yeah, this doctor got a letter. It says the purpose of this letter. Now, this doctor didn't get fined, didn't have to suffer any penalties. He got a letter. It says the purpose of this letter is to educate and inform you that our office, this is Medicare, that our office received a complaint alleging that you knowingly process Medicare claims as if the patient is paying their co-payments, but the patients are not. Okay. Here's another letter. Cigna asked the doctor for records, plus, I'm seeing this more and more, copies of patient billing and collection ledgers, documents that show when the bills were sent to the patient and how much money has been paid by the patient. So just be aware here. There's another one from Aetna. After contacting some of your patients, it has come to our attention that you routinely waive all patient responsibility. So, there are certain strategies that you should be aware of when it comes to co-pays and deductibles to make it more compliant. Okay, now we've broken down here. Every man, woman, and child that comes into your office will fit into one of these 8 paying categories, reimbursement categories. Cash has 4 subcategories. In-network, out-of-network, Medicare, PI, discount medical plans, health savings accounts, and direct primary care. So cash, okay. Patient comes in, cash. Great, they could pay as they go. It's $50 each time, Mrs. Jones. Okay. Or prompt pay. Mrs. Jones, our normal fee is $50, but since we're not going to be billing your insurance, or you're going to just pay cash because you have a huge deductible, we'll give you a prompt pay discount. How about 20%? So instead of 50, it's 40. Okay, let's go to C, prepay. Oh, do you want to save an additional few dollars? Well, you could prepay. So if we're going to give you $50 adjustments and we're going to recommend 10, if you pay as you go, that's $500. If you prepay, we'll take off 10%. So that comes out to $450 if you write us a check right now up front. Hey, that's a possibility. And then the final category, hardship. Patients might say, I can't afford this. I don't think I can receive the treatment if I have to pay this. So work out a plan there. In-network. Okay, in-network. How do you maximize reimbursement? Find out what's covered in the plan. You'd be surprised how many doctors will say, oh, Marty, doesn't matter what we do. We get $60. Doesn't matter if we just do an adjustment or we spend an hour with the patient, we get $60. Yeah, but did you know that this plan also pays for blank and this dot? Oh, I didn't know. So do your research. Out of network, how do you maximize reimbursement? Well, do you want to accept assignment or not? That's the big difference. You could maximize reimbursement by having the patient pay you in full, or if you're going to accept assignment, do you want to accept the allowed amount? That's where, in my opinion, there's a little wiggle room depending upon what you charge and what the insurance company allows. Medicare, you have par and non-par. So be aware, you're either par or non-par, or you do not accept Medicare patients at all. If you're a doctor that's saying, I take Medicare patients, yeah, we take Medicare patients, but we don't bill Medicare. We don't want to bill Medicare. The patient just signs an ABN form, and we just take cash. We don't bill Medicare. See, that's illegal. Yeah, I know. A lot of you might be shaking your head. Stop. If you don't want to bill Medicare for spinal manipulation, you just, I don't want to bill Medicare. I don't want to get involved with Medicare. That's a federal program. Then you cannot see Medicare patients at all. What did you say, Dr. Kotler? If a Medicare patient comes in and I just do an exam, Medicare doesn't pay for exams. I could have them pay me cash. I don't have to bill Medicare. I'm not enrolled. You have to be formally enrolled. Or just don't take Medicare. You don't have to take Medicare patients if you don't want to. By the way, if any of these things are like, wow, I'm having light bulbs flashing over my head right now, set up a 15-minute consultation with us. We don't charge for it. Okay, number 5, PI workup. Yeah, you have to abide by the fee schedule. Discount medical plan organizations like Cairo Health USA. Cairo Health USA, in my opinion, is the #1 discount medical plan organization in the country. This is an organization that gives back to the profession more than most other companies. Patient joins the club. You're part of the club, so now you could discount your fees as much as you want. You set the fee. If you want to make your chiropractic adjustments $15, you could do that. You want to make it $150, you could do that. You're in control with DMPOs. It's one of the best ways to avoid a dual fee schedule, if not the best way. Health savings accounts, to me, that's pure cash. Give the patient a walkout receipt. Pretty straightforward. Direct primary care, it's only available in 25 states. This is where you create a monthly agreement with a patient for whatever services you want to provide. If you want to provide, let's say you want to tell a patient it's $500 a month, you can come in as much as you want. Many, many years ago, there was something called unlimited care at a fixed fee, UCAF. Some of you may have remembered that. Unlimited care at a fixed fee. This is one way to do unlimited care at a fixed fee. Mrs. Jones, it's $200. You can come in as much as you want. Next patient, it's $200, but Mr. Smith, it's limited to 1 visit per week, so these are the 8 categories. Now, here's something that gets a little confusing. You have the doctor who's the owner of the practice, and the owner of the practice hires an associate, and the associate is out of network. The owner of the practice is in network with all the plans and hires an out-of-network doctor. Now the out-of-network doctor is treating the in-network patients and billing with the owner's name on everything. That is not okay. Vice versa. The owner of the practice is out of network and wants to bill out of network because you get paid more in certain situations, but wants more new patients, so hires associate doctors that are in network. So now patients are coming in because they see that the associate doctors are in network, and then the patient is being billed with the owner who's out of network. Careful, make sure 24J, 25, and 31 make sense. So 24J, whoever's touching the patient, that person's NPI number needs to be in 24J, the NPI number right there. Box 25, the tax ID number, that stays the same regardless of who's touching the patient. And who's ever touching the patient, that person's name should be in 31. So if you have an owner of the practice that's in network, and now you hire an associate doctor that's out of network, whose name is in 31? Whose name is in 24J? I'll tell you who should be in there. Your associate doctor's NPI number should be in there. And you need to get your associate doctor in network also, or else you could be accused of insurance fraud and bait and switch. Careful with that. Now we have these situations where, Dr. Kotler, sometimes patients come in and we think they've reached, wellness care, but the patient still thinks it's medically necessary. So the patient wants us to bill the insurance, but we don't think it's going to be covered, right? So just make sure you understand, medically necessary care is insurance payable. Medically necessary means the patient has pain, restricted motion, can't do their normal activities of daily living. Guess what? Chiropractic works well, right? It works very well. After what? 6, 8, 10, 12 visits, 15 visits, the patient is going to get to the point where they have very little pain. Range of motion is really good, and they can do just about all their activities of daily living. When they get to that point, it's not payable anymore. And my recommendation is either before you walk into the room or after you walk out of the room after seeing a patient, you have to make a decision. Was that encounter active care or maintenance wellness? You could put here we go again. You could put every man, woman, and child in your practice and place them into one of these two categories on every visit. You walked out of the room. Whoa, was that active care? Okay, then we're going to get paid by insurance, or the patient has to pay cash. Or, oh, wait, that was a wellness or maintenance encounter. Well, that's cash. Don't get caught in the middle, which means you're providing wellness services, and that's what your documentation looks like, but you're billing the insurance just to make the patient happy, probably. Now, I mentioned, prompt pay. So my normal fee is $100, Dr. Kotler, but now patients are coming in that don't have insurance and they want to just pay cash, or they have high deductibles. Could I give them a discount? Instead of $100, could I discount my fee 10%, 20%, 30%, 60%, 80%, 90%? How much of a discount? Okay, so if you want to know what Blue Cross Blue Shield says, contact them. I've never read anything about it. If you want to know how much you want to discount, Aetna patients, I can't tell you. I could tell you what the federal government says. Federal government says about 15%. So why don't you just apply that across the board? Now, I have done research into many states. I have clients in about 30 states, and just about every state I contact the state boards. And I ask them, how much could a chiropractor discount in your state? I'm a consultant. I have clients in your state. They need to know the answer. How much could I discount? Some states have said you can discount as much as you want, 90% if you want. Other states say, oh no, we go by the federal guidelines. Other states say, we don't have an answer. So make sure you know what you can do. Very important. What about, okay, Dr. Kotler, I want to give away a free exam. Can I give away a free exam? Could I give away a free exam to my cash patients, my Aetna patients, my Blue Cross Blue Shield patients? Well, I have the answer from one reliable resource. That's the federal government, the OIG. They say you want to give a patient a gift, you want to give something away for free. If it's a Medicare patient or a federally funded patient, the value cannot be more than $15 each time or $75 total for the year. So here comes Mrs. Jones. You want to give her a free exam. Is your exam valued more than $15? If it is, then you can't do that with a Medicare patient. So Dr. Kotler, can we do it with our Blue Cross Blue Shield patients, our Cigna and Aetna patients? I've never seen anything in writing from them, so why don't you go try and find it? Be careful, you might not want to poke the bear, So now, here, look at this doctor. This doctor from Iowa, he had to pay $79,919 to resolve allegations he violated the False Claims Act. What did he do? He provided free electrical stim to Medicare patients to influence them. That's what they're charging him with, inducement, influencing the patient to receive chiropractic adjustments by giving away the free stim. So patients were coming in. Yes, I don't know this doctor. I don't know what happened. I don't know why he was doing it. I'm just going by this document. So patients were coming in, they were getting free electrical stim, but he was billing Medicare for the adjustments. So I guess, the message here is don't give away anything for free to Medicare patients unless the value is 15, but that's only one time. Now, how did they even find out that he was giving away free stim? How did the U.S. Attorney's Office find out? I don't know. I could tell you there's one of three things. One, a disgruntled employee reported the doctor. Number two, an unhappy patient, or a jealous competitor, maybe a jealous doctor down the road. Somebody reported him, so you always want to be proactive and be careful. And if a patient is going to accuse you of something, you should have a policy on what you do. If a disgruntled employee is going to accuse you of something, you should have a policy that this employee signed, that they understand your policies. So now the financial report of findings, you always want to make sure that patients understand your financial policies. It gets them to realize that collecting money from insurance companies is not that easy. You should educate patients about maintenance care, letting them know that on one hand, this is the way we train our staff members. For those doctors that want to collect insurance money, we say something like this: Mrs. Jones, you have insurance. The good news is you have insurance, and your insurance covers chiropractic. And what we want to do is make it so you have as little money out of your pocket when it comes to the insurance billing. We want to make it so you have as little money out of your pocket as possible. Now, you're going to get to the point where you're feeling great. Chiropractic works wonderful. In a few weeks or a couple of months, you're going to be feeling fantastic. When you feel fantastic, your insurance doesn't pay. So that's when you'll get put on a wellness or maintenance program. And this is how it works. Insurance doesn't pay. Plant the seed right away. Now, when you're billing insurance, you might get these, we're not paying because the services were not medically necessary. So make sure you understand what medically necessary is. I mentioned it earlier. Patient has pain, restricted motion, decreased in function. So you send in your notes and it comes back, not medically necessary. And then these are some of the most common reasons. Be prepared to fight these. Your notes don't show enough improvement. Functional limitations have been met. Procedures have not been effective. Goals have not been established. The notes appear as though it's maintenance. The time component is missing. You're not using the 59 and 25 modifiers properly. You didn't document the specific subluxation levels that you adjusted. The notes are not legible. There's no signature. So be prepared to answer these types of, or just be proactive. Go and look at your notes right now and see if you're checking all these boxes. Do my notes show that the patient is improving? Am I using the modifiers properly? Did I sign the notes? Are the notes legible? When I'm billing Medicare, does it say I adjusted C5, C6 instead of I adjusted the cervical region? Now, you could also get a denial saying, oh, denied until we see the notes. Wait, did you just get put on a prepayment audit? This is going on a lot lately. This is a doctor from, I think, New York, where the insurance, Empire Blue Cross Blue Shield, yeah, that's New York. They said, well, we've been analyzing your bills, and based on your bills and some of the notes that you sent in, we're putting you on a prepayment audit because there are no signatures. It says it right on the letter. There are no signatures. The treatment plans appear templated. There's no plan of care. The testing did not change the plan of care. Some members' treatment indicates years of the same treatment without improvement. Therefore, you're going to be put on a prepayment review. And that causes nightmares here. And it's coast to coast. This is Blue Cross Blue Shield of California saying, okay, doc, we're putting you on a prepayment audit now, review. So you have to send in your bills and your notes. It becomes administrative nightmare, just to let you know, once you get put on a prepayment review, because it says the records we reviewed do not contain a treatment plan, nor do the records state that the exercises were performed. There's no start and stop times, and how the exercises were tolerated by the patient. So when you see these letters from coding experts like me, they show you these sample letters. These are doctors that I've helped get out of these prepayment audits and help negotiate payment reductions. These things that I'm reading off, you should be looking to see, hey, this is what the insurance company found, that there was no plan of care. So what you should be thinking is, oh, I better have a plan of care. This says the treatment indicates years of the same treatment without improvement. Oh, let me go, so these are just little wake-up calls. So keep your fee simple. Fee confusion is one of the most common causes of board complaints. A patient comes in, let's say the patient has to wait an hour and they're upset. They're probably not going to file a board complaint. You have a patient come in, and your front desk receptionist is a little abrupt and rude and nasty, the patient is probably not going to file a complaint with the board. But if you mess with the patient's pocketbook, you overcharge them, or they think you're ripping off their insurance company, or you're billing them too much, or you're billing them something that they weren't expected that they had to pay, they will file a complaint with the board. I'm helping a few doctors right now get out of board complaints. I have a doctor, because of his sloppiness and board complaints, he's on a 5-year probation. So he had to hire a consultant to, it's like I feel like I'm a parole officer. This doctor has to report to me every month. He has to show me 10 soap notes every month for the next 5 years. And I have to write a report and give it to the board to tell them how he's doing every month for 5 years because of a board complaint. So, tell patients that if you're going to give them a discount, tell them what your normal fees are. Now, doctors, this is you look out into the waiting room, this is what you should see. Oh, there's Helen, she has headaches. There's Rob, he has rotator cuff syndrome. There's Sally, she has sciatica. Oh, there's Norman, he has neck pain. And there's Kathy, right? You should be looking at patients from a clinical standpoint, how to help them. Your billing staff, your front desk receptionist, this is how they should be looking out into the waiting room. Oh, yeah, there's Ann. She owes me $50. Oh, yeah, there's Norman. I get a pre-authorization from him. Oh, yeah, there's Betty. She owes me $240. She keeps telling me she's going to bring in the check. She never does that. Oh, there's Mark. I got to get an ABN signed on him. There's Carla. Oh, boy, her credit card declined. I got to get an updated credit card. Oh, there's Nancy. Cigna's waiting for the notes. I got to go talk to the doctor again and get the notes out, right? So, doctor, you should be just thinking, when I see patients like in a supermarket or, at an event or a party, I go, oh yeah, there's Jerry, carpal tunnel syndrome. Like, I don't remember what their insurance was or how much they paid. I associate them with a condition. Your staff, you see somebody, you see, Allison at a cocktail party, you should go, Allison, you owe us money. You owe us $240. No, don't do that at a party. Wait till they come in. All right, so I'm going to close today's presentation with my 9-step action plan, and then we're going to get to questions and answers. Step 1, get proactive. What does that mean? That means don't wait for the oil light to flash on the dashboard. Get out of the car, open the hood, check the oil. Do the things that I just went through to be proactive. Step 2, this is for staff members. Make sure you get all new patient forms signed and totally filled out by the patient. Before you let the patient see the doctor, make sure everything is filled out. Step 3, doctors, this is for you. Review the paperwork. Review all the forms that the patient fills out prior to going in. You don't want to miss something, which can cause a problem down the road. Step 4, review the policies from the insurance companies you bill the most. Step 5, understand code pairing, or the what and the why. Your CPT codes are what you're doing. Your ICD-10 codes are why you're doing them. So if your CPT code, let's say, is traction, mechanical traction, that's what you're doing. That's 97012. So what are you doing for? Maybe something like cervical disc degeneration. That's your diagnosis code. So make sure you understand the what and the why, and you're combining them. Like, here. Have any of you ever been to a wine and food festival? I love going to them. I love learning about how to pair wine and food to make that ultimate culinary experience. Find it very interesting. Well, you should be pairing your CPT codes and your diagnosis codes. For example, patient comes in with cervical radiculopathy. That pairs beautifully with mechanical traction. Patient has myofascial pain in the neck. That's M7912. That pairs fantastically with myofascial release, 97140. So I like pairing. Oh yeah, I consider myself a coding sommelier. You ever hear that word, sommelier? It's a French term for a wine pairing expert. I'm a coding sommelier. I'll pair your codes. There we go. Want to do therapeutic exercises on a patient? They have to have something that pairs nicely with exercises like what? Shoulder stiffness. So if I'm going to do exercises to increase range of motion and decrease stiffness, then shoulder stiffness pairs very nicely. All right, step 6, do a self-test on your notes. Make sure your notes, you know what they look like, and score yourself. That's part of audit training. You should do a self-review of your notes once or twice a year. That's it. Twice a year, pull a couple of charts. Score yourself. We have a chart audit tool. Gold members of Target Coding, hopefully you're using our chart audit tool to score yourself twice a year. Step 7, always keep learning. Attend seminars, attend webinars, be a sponge. You should always be trying to learn how to help more patients, improve your business. Step 8, put together a simple policy manual. Explain it, what you do and why you do it. For example, in my practice, and a lot of you, patient comes in just with neck pain. Do you check the thoracics? Do you check the lumbars? So a patient comes in with neck pain, I'll adjust L5, even though the patient has no problems there. So now my notes say adjusted cervical, thoracic, lumbar, sacrum, and now I'm only billing 98940. If you're audited, the insurance company could go, is this doctor why is this doctor treating 4 regions but only billing us for 1? Seems weird. What's going, so have a policy. Just in case you get pulled over, you have a good reason. And step 8, conduct regular meetings, especially with staff members that do your billing. Also, if you're using a billing company, please do a spot check. I'm dealing with 2 audits right now. Both doctors are being audited. They didn't realize that the billing company was doing, one billing company was adding the 5.9 modifier on codes that didn't need it. Doctor got audited, didn't know that the billing company was doing that. Another doctor was doing a 98940, and the billing company was billing 4.1. the doctor was doing 1 unit of rehab, the billing company changed it to 3 units. Doctor didn't know until the doctor got audited and did research. So you want to just be proactive, just in case you get that knock on the door, right? You want to do this so you could SWAN. You see that acronym, SWAN? SWAN? It's one of our favorite acronyms. It means sleep well at night. You want to be able to SWAN. So let's take a look and see what questions have come in. I want to thank everybody for attending. Here's my contact information. You can email me directly. Again, you want to learn more about what we do or something I said in this presentation, call us or email us and set up a free consultation. Pick my brain or ask questions. Do it. All right. So, just a couple. Besides these webinars, we do seminars all over the country. I've written a book on how to maximize reimbursement. One of the things in the book is showing you about 25 of the most common diagnosis codes in chiropractic and the ortho, neuro, and subjective tests to substantiate it. Little clinical stuff in here. This part of the book, Chapter 1, goes through the codes that pay the most visits. They're called long-term treatment codes. If a patient has that, you should use these. And this is back to the pairing I mentioned. Show you how to pair your codes. Here's an example. 97110 pairs beautifully with a whole bunch of these codes here you see on your screen. We also provide you with these cheat sheets. Oh, yeah, we also have a package of forms. Over the last 12 years, I've put together probably 500 forms, letters, and templates. I've taken my greatest hits, 75 of my greatest hits of forms, logs, and templates, and we put it in a package, and we've broken it down into new patient forms, financial and administrative forms, exams and treatment plans, a whole bunch of sample SOAP notes, tons of fight-back letters, letters of medical necessity, appeal letters. I threw in a few PT and acupuncture forms, Medicare forms, all the basics are right there, ABN. I give you a sample initial chiropractic visit for Medicare, regular visits, and a whole bunch of HIPAA forms are included. Compliance plans is something we specialize in. We'll put together a personalized, customized billing and coding manual for you with written policies and procedures. This is being proactive, putting together, and it's not that extensive, and it doesn't take that long to do. With us, it takes 2 to 3 phone calls. We interview you, we find out what you're doing, we put together the policies and procedures, we mail you the 3-ring hard copy binder and a disc with all the forms, all the templates, so you can customize them when we're not around. So we do that for billing and coding, and we also do it for HIPAA. And we do this for PTs and acupuncturists. We have 11 videos on our website, 11 videos that we sell. All right. So again, I want to thank everybody for attending. We're going to go and take a look at the questions right now.